The musculocutaneous nerve is the primary power source for the anterior compartment of the upper limb. To understand how it operates, we have to start at its exact point of origin. It arises directly from the lateral cord of the brachial plexus. The specific spinal roots that feed into this cord and ultimately form this nerve are C5, C6, and C7. This combination creates a mixed nerve. It operates as a two-way street, simultaneously carrying outgoing motor commands to muscles and incoming sensory data back from the skin. Tracking the exact physical route this nerve takes down the arm makes its motor and sensory targets logically predictable. This flowchart lays out the systematic framework we will use to trace the nerve from its origin to its termination. Looking at the first column, we anchor our starting position at the lateral cord before we begin our descent down the arm. Establishing these base root values and this point of origin is the mandatory first step before we can map its physical navigation through the axilla. We begin the topographical trace in the axilla, or the armpit. The precise landmark where the nerve emerges is exactly at the lower border of the pectoralis major muscle. Immediately, it establishes a tight vascular relationship, positioning itself lateral to the third part of the axillary artery. At this stage, the nerve is boxed in by four distinct boundaries. Anteriorly, it is bordered by the pectoralis major. Posteriorly, it rests against the subscapularis. The medial boundary is defined by the axillary artery, and laterally, it is flanked by the Coracobrachialis. This dense clustering creates a tightly packed anatomical corridor, which makes the nerve highly susceptible to localized trauma before it even has a chance to enter the arm. To perform its primary function, the nerve must escape this axillary confinement. It achieves this through a definitive anatomical maneuver, a hallmark sign used by anatomists to identify the nerve during dissection. It physically pierces right through the belly of the Coracobrachialis muscle. As it pushes through the tissue, it drops off its first muscular branch, delivering motor supply directly to the Coracobrachialis. Free from the axilla, the nerve now runs downwards and laterally, moving deep into the anterior compartment of the arm. Here, it finds a protected pathway, sandwiched securely between the biceps brachii, which sits superficial to it, and the brachialis muscle, which lies deep. While traveling through this corridor, it makes its critical motor deliveries, supplying both the biceps brachii and the brachialis. Along this route, it also drops off minor articular branches that provide innervation to both the shoulder and elbow joints. By routing directly through and between the major flexor muscles, the musculocutaneous nerve is optimally positioned to act as the master controller for elbow flexion. We track the nerve down to its next critical juncture, the area just below the elbow joint. By the time it reaches this point, the nerve has completely exhausted all of its motor fibers. Consequently, its physical depth changes. It pierces the deep fascia, migrating from a protected deep position to a superficial one just under the skin. Because its function and location have changed, its name changes as well. From here on out, it continues as the lateral cutaneous nerve of the forearm. In this final stretch, its role is exclusively sensory, collecting data from the surface of the skin. Looking at this diagram, the dark shaded regions outline exactly where this sensory territory is located, along the lateral aspect of the forearm. This physical transition from deep muscle motor control to superficial skin sensation is the definition of a mixed nerve in practice. With a complete anatomical map established, we can use it to interpret clinical pathology and injury. Common causes of injury to the musculocutaneous nerve include fractures of the humerus, penetrating injuries to the axilla, or collateral trauma during surgical procedures in the shoulder region. Based on the motor deliveries mapped earlier, damage here results in significant weakness in elbow flexion, directly caused by the loss of innervation to the biceps and brachialis. There is also a secondary motor deficit, notable weakness in supination of the forearm, primarily because the biceps, a major supinator, is denervated. This list details the clinical outcomes. Alongside the motor weakness, the anatomical sensory transition we traced correlates directly to the third point, a distinct loss of sensation over the lateral side of the forearm. By recognizing this specific grouping of motor and sensory symptoms, a clinician can logically reverse engineer the problem and pinpoint a lesion on the musculocutaneous nerve. To confirm exactly where the damage occurred, we look for a characteristic diagnostic feature that distinguishes a high-level lesion in the axilla from a lower arm injury. Paralysis of the coracobrachialis muscle is the definitive indicator. The coracobrachialis is the first structure the nerve pierces and innervates immediately upon leaving the axilla. If it is paralyzed, the lesion is located at or before that initial point of exit. The entire topographical journey, from the axillary origin descending through the anterior motor compartment down to its superficial sensory termination, is a single continuous system. This specific spatial routing provides the internal logic for every clinical outcome.